Good afternoon. I'm Sandra Arevalo, Director of Community Health and Wellness at Montefiore Nyack Hospital, here from Nyack, New York, in a snowy, kind of icy, cold day anyway. And today we're going to be talking about influenza, or better known as flu, and asthma. And as I like to say, it's where the two of them meet, which is not a very nice thing to be going through, I guess. And for that, we have Matthew here, who has joined us in other community chats sessions. And he's going to be talking to us about, flu and asthma and what to do if we happen to be in that nasty situation. So thank you so much, Matthew, for being here again. And if you don't mind telling us, which organization you belong to, please do.
Yeah. Thank you so much, Sandra. And thank everybody for joining. Again, my name is Matthew. So I work for the biotechnology company called Amgen, and pharmacist by training, and I'm on their medical side. And very excited to talk with you all today, like Sandra alluded to, both about influenza and layering into that asthma, and then pivot from there and focus on a core area of asthma management, from what is asthma to how can asthma be managed. And we'll spend the latter half of our presentation focusing on that. So am I good to jump in, Sandra?
Please do. Please. Yes.
Great. And I will acknowledge too, as I'm beginning to screen share, recognizing this presentation is for all of you. We want this to be interactive. So if you have any questions throughout, if I could review something, better explain, please pepper the questions in the chat. Between Sandra and myself, we'll keep an eye on those, and then go from there. So we'll go ahead and kick it off. So the program we're looking at is called LUMA, Learn to Understand and Manage Severe Asthma. And as I just mentioned, what we'll focus on first are some kind of more specific topics in the asthma space. First, we'll look at asthma disparities, and then from there pivot to asthma and influenza or flu. And then finally round out the discussion with asthma, from what it is to how is it managed, and really working toward empowering you to become better informed and manage and control your asthma. And the flavor is really, it is severe asthma, but there's really a lot of information here for patients with mild, moderate, or loved ones with asthma, perhaps if you're a caretaker. So let me go ahead and advance to the next slide. And as previously shared, so I do work for Amgen, and this presentation is being presented on behalf of both my company, Amgen, and also AstraZeneca, the sponsors of this program. But it is following all compliance requirements with the FDA. So it's educational and not a specific therapeutic or a representation of any specific therapy. So I won't be able to answer specific drug questions during this presentation. So to kind of, help get us engaged and thinking about asthma, we have a few pre-post questions that we'll talk about. Feel free to, as we're working through these questions, drop your answers either in the chat or perhaps just think about these in your head, because the answers for some of these will be peppered throughout the presentation. So hopefully if you don't know now, at the end of the presentation, you'll have been able to identify the appropriate answer. So first question is, how well do you understand your asthma? A, I'm a beginner. B, I have some basic knowledge. Or C, I'm an expert. All right, so I'm seeing some basic knowledge, some expert comments or expert answers coming. Or I'm sorry, basic knowledge and beginner coming through. All right. So next question. How is asthma severity determined? A, by symptom severity, such as the wheezing, the shortness of breath. B, by the frequency of asthma attacks or exacerbations is another word you might hear. C, by the type and amount of medications needed to control those asthma symptoms. or D, by the types of triggers such as cat dander, pollen, ragweed that cause the asthma symptoms? All right, so I'm seeing some A's, some C's come through. Appreciate the participation. Okay, true or false? The immune system can be the underlying cause of a person's asthma. A, true, or B, false? Seeing some trues come through, or choice A. All right. A, B, good. And then finally, as we talk about patients with severe asthma in this question, they are recommended to A, see an asthma specialist like a pulmonologist, a lung doctor, or an allergist. B, work with their provider to create a written asthma action plan. C, track their asthma through an asthma journal, or D, all of the above. So again, patients with severe asthma, which one or ones of these are recommendations for those individuals? All right, seeing some D's come through for all the above. All right, and again, we'll come back to the actual answers at the end of the presentation. So first, we'll touch on asthma disparities among specifically Americans here, and we'll look at some disparities among specific races and ethnicities, and then from there look at the why, and then perhaps how we can better address the why, both as a collective community, myself from industry, yourself as patients or loved ones with asthma, community stakeholders like Sandra. So how can we all partner to really bridge the gap and reduce these disparities in patients with asthma? So first, just some brief statistics. And on this slide, we're looking at Black individuals and comparing outcomes compared to white Americans. And what you can see is that left to right, Black individuals are more significantly impacted by asthma than their white American counterparts. This extends from diagnosis of asthma to hospitalization, where Black Americans are 2 times as likely to be hospitalized, 5 times as likely to visit the emergency room, and then unfortunately, in the way of mortality, 3 times more likely to die from asthma. And more specifically, the highest death rates are noted in Black women. So clearly across the board, there are disparities among Black individuals compared to white Americans with asthma. Next, looking at Hispanics, patients with asthma, both Hispanic individuals and then white individuals, again, both with asthma. Across the top, you can see education, access to healthcare, and then finally, environmental pollution. Across all three of these domains, you can see that more individuals that are Hispanic are reported as having less than high school education. Greater Hispanic individuals have less access to healthcare, so 27% versus 17% white. And then finally, in the way of environmental pollution, there ends up being a higher pollution burden among the Hispanic population. So 63% versus 17% for white individuals. And then dialing in a little bit more, Puerto Ricans actually have the highest rate of asthma prevalence compared to any other race or ethnic group. And that becomes especially important as providers are considering perhaps a diagnosis and reflecting on race, ethnicity, perhaps, and also, thinking about clinical trials representing the individuals most impacted by asthma. So why are there these disparities? And really, there's different ways to approach and bucket these different themes. But the Asthma and Allergy Foundation of America, I think, do a digestible approach toward recognizing these disparities and then perhaps addressing them. But they've grouped these into a few different domains. The first one being social, and this can relate to economic stability, such as poverty or employment, education as well, that we just talked about, and the disparities there between Hispanic individuals and white individuals. Structural components, so access to quality healthcare. Racism and discrimination, we know, are still very common today, unfortunately, and those can be a significant contributor to the disparities. Non-adherence to treatment, and perhaps this relates to beliefs and trust in treatment in the healthcare system. And, I'll be the first to recognize there's definitely significant mistrust in the healthcare system based on significant wrongdoings in the past that, collectively communities are continuing to work to address, to bridge those gaps with patients and communities as well. Tobacco use can also be a contributor toward those disparities. And then finally, some things that may be a little bit more front of mind, but smoke and pollutants, like we had talked about, and also a genetic susceptibility too. So some patients, whether relating to the disease state itself, asthma, or treatment response, there can be a genetic consideration that can influence those different components. And importantly, we've talked about the statistics, we've talked about the why, but how can we really work to reduce those asthma disparities? In that same organization that I referenced, the Asthma and Allergy Foundation of America, they've categorized these different approaches into policy, research, education and communication, and importantly, partnership. Policy becomes extremely important as we work toward ensuring individuals have health insurance coverage to see the providers that they need, receive the treatments that they need, and more. Working toward bridging and increasing the minimum wage for individuals and reducing that racial wage gap, as well as the sex wage gap between males and females. Ensuring access to not only affordable housing, but quality housing. And we'll talk about that in regards to some of the lifestyle modifications that you can make around your house. And then working toward ensuring reductions in exposure to pollution and known environmental triggers. We've talked about research a little bit, but essentially some of the essence here is one, representing those impacted by the diseases in the clinical trials. So Hispanic individuals, Black individuals, disproportionately affected, but often underrepresented in clinical trials. So really working toward representing those populations that are most impacted, and improving data collection of those endpoints relevant to patients, right? So patient-reported outcomes, what matters to you most as a patient in terms of feeling better, activities of daily living, et cetera. And then not only for the patients, but the researchers as well, we want to ensure that there is diversity across the research and investigators that are participating in clinical trials and different research. Education and communication is what we're doing here today. And then finally, partnership. This doesn't fall ultimately into one team's bucket, if you will. This is a collective effort from policymaker, from industry, from the community, and other core stakeholders to work toward reducing these disparities to ultimately improve outcomes for you or a loved one with asthma. Okay. Any questions on asthma disparities before we jump into a few slides on National Influenza Vaccination Week?
I don't see any questions right now in the chat.
All right. Thank you for monitoring too. Appreciate that. Okay. So when we talk about flu or influenza, both the same terms there, one thing that comes to mind is National Vaccination Week. So in terms of minimizing risk for getting flu or flu-related complications like hospitalization, vaccinations play a critical role. So in December every year, we have National Vaccination Week. So a little bit of a call to action as you consider appropriate vaccines for yourself. And we know that the annual influenza or flu vaccine can help protect against the flu. And I'll be the first to acknowledge that it's not a silver bullet, right? It's not 100% effective. But with that being said, if you do end up getting the flu, having the flu vaccine on board can reduce your complications from the flu, such as going to the hospital, getting pneumonia, etc. So the vaccine can work toward, again, preventing flu and getting the virus, if you will, and infected with it, or minimizing the complications associated with flu. So, two strong reasons to consider getting the vaccine as appropriate. When we talk about flu season, it varies year to year, both in terms of like timing and also what different strains of flu are causing those peaks that we hear about in the news. But often begins to increase in October. So we're starting to see the trend upward, and generally peaks between December and February. And that's really represented on the right-hand side in the visual here. So you can see that in terms of the peak month here within the US, from 1982 to 2022, the peak flu season month has overwhelmingly been February. And then December, January, and March kind of round out second and third there. So we are starting to trend upward, and it's really still a good time to consider getting the flu vaccine if you have not already. But who's at high risk for complications? Patients with chronic or long-term conditions, including asthma, diabetes, heart disease, those individuals tend to be at greater risk for developing those flu complications that we've mentioned. So going to the hospital, perhaps getting pneumonia, those flu-related complications, that risk is higher in patients with asthma and other long-term diseases. And overwhelmingly, the patients that end up being hospitalized, 90% of them have an underlying medical condition like asthma. And then again, reflecting on some of the racial and ethnic disparities that we had talked about, non-Hispanic Black, non-Hispanic American Indian or Alaska Native, as well as Hispanic or Latino persons are also at increased risk. So not only is there a comorbid chronic disease consideration, but also race and ethnicity, because these patients are more likely to have an underlying medical condition. So what are some things that you can do to protect yourself? So I think I've, alluded to the flu vaccine. So that's, a key one. But some other things that you can do are ensuring that you wash your hands often with soapy water, especially if you're coughing into your hands, covering your mouth, your nose with the tissue if available. If not, sneezing into your elbow, right? So that you're not spreading germs that may have landed on your hand if you had coughed into your hand. Easier said than done, but avoid touching your eyes, nose, mouth, because that's how the different viruses, bacteria can really get into our bodies. And then importantly, stay home when you're sick. And one thing that I think came out from COVID is that if you are feeling sick, you don't need to tough it out and go to work, right? So employers, individuals, friends, I think there's a lot more social acceptability around staying home if you're sick to minimize spreading any disease and getting medical care if needed. So that rounds out the flu-related content for the presentation. Any questions on that before we advance into kind of the foundational core content that we'll be going over?
I do have a question, Matt. Do you
Sure.
have any statistics as to how sick or how many people that don't get the flu vaccine do actually get flu every year?
I don't, but I would guess like if we take a snapshot of all those individuals that got flu, vaccinated, unvaccinated, I'd hedge my bets that the majority are individuals that are unvaccinated. And then if we look at that same group, people that got flu, in terms of the individuals that got flu complications, right? Hospitalized, pneumonia, et cetera. I would anticipate it would be a similar finding that the unvaccinated individuals had a higher incidence of flu-related complications as well. But I can circle back on that. I don't have any hard statistics off the top of my head around that.
No, but your answer kind of goes in sync with what I've just noticed in the population in general. You know, it's like a lot of people think that because they get the vaccine, they're never going to get the flu or COVID or whatever.
Right.
You can still get it. It's just that you're not going to get as much of the complications, right? Like you can avoid hospitalizations, for example, even death sometimes. And that's
Yeah.
what people, I feel like that's what people need to understand. It's not an I'm not gonna get it kind of thing, but it's if I do get it, it will protect me.
100%. And I think
Okay.
that's in that we continue to like educators, right?
Yes.
Continue to try and reinforce. And it would be great if we had a flu vaccine that was prevented 100% of infections from the influenza virus, right? Unfortunately, that doesn't exist. But you mentioned a great point in terms of minimizing complications if you do get infected. And importantly, think of the vaccine that you get as a scientist being a weatherman, if you will. So, based on previous data from past years, when the flu vaccine is generated, best guess for the upcoming flu season and what is going to be like the dominant flu strain, right? Because there's lots of flu strains out there, and the vaccine is our best guess, right? So we're trying to forecast the weather, if you will. Generally, pretty decent job, but some years it's off, but it minimizes the risk for complications as well.
And that's an important point. It's like the flu changes. It looks like it's a mutant, right? Like
Yeah,
every year it can be different. That's the reason why you need to have a new vaccine every year because you
exactly.
need to be protected against this new version of a flu. So, okay.
Great.
No further questions.
All right. Thank you. So now we'll jump into the key messaging around asthma from learning that asthma is a chronic disease, specifically of airway inflammation. Then from there, understanding the role that the immune system plays, and then finally rounding out with the role that you play in managing your asthma care. So first, asthma is a chronic disease of airway inflammation. So, a couple of things I want to call out here, just so we're on the same page. We've talked about chronic disease on past slides, but just thinking this means long-term disease, right? So, think about this like similar to diabetes or high blood pressure. They can absolutely be managed, they can absolutely be controlled. But generally speaking, once you have that diagnosis, that diagnosis is with you for life. It's a long-term or chronic disease. And asthma specifically is a disease of the airways, and it is an inflammatory disease. So similar to perhaps stubbing your toe, when you see that redness come through, that represents inflammation. Similar signaling and talking within your airways taking place in patients with asthma, and we'll touch on that momentarily. So before we jump into some of the key information and definitions, which are always important, I think it's important to recognize that there is a large asthma community out there. Here within the US, there's about 25 million individuals that have a diagnosis of asthma, severe, moderate, mild. And from those 25 million, about and up to 10% actually have severe asthma, which we'll define shortly. And from these patients with severe asthma, again, 10% or 2.5 million, half of those individuals, so over 1 million individuals, have severe uncontrolled asthma. So the bottom line here is that asthma is very common across here within the US, and that there is still a substantial burden of patients that have severe and uncontrolled severe disease. And we'll talk about those definitions coming up. So actually, right on this slide. So how do we define severe asthma? If you take away nothing else from this slide, severe asthma is defined by the medications a person takes for asthma, bottom line. If we want to dial in a little bit more, severe asthma is specifically patients with asthma that require one cornerstone of therapy, which would be an inhaled corticosteroid. So it comes in an inhaler, and it's specifically the high dose inhaled corticosteroid, and another controller medication, a long-acting beta agonist. So one that you would take daily, sometimes twice daily, that remains uncontrolled despite treatment with these medications. So severe asthma is based on the medications a patient takes. And you can see down here, and we'll talk about these different pieces of the pie. There's lots of different options for the management of asthma, which is fantastic. So want to call out, though, that despite using higher doses of medication, reducing risk, and following treatment plans, patients with severe asthma may not have their asthma in control and can experience severe asthma attacks or exacerbations. So we can talk more about how we can capture asthma management, daily tracking to aim for that goal of control. And that's what brings us to this slide. So you can have controlled severe asthma, but some patients may actually have uncontrolled severe asthma. And how do we find that and what is it? Well, from an asthma lens or standpoint, uncontrolled asthma occurs when the symptoms like the shortness of breath, the wheezing, they're still there despite following your asthma action plan, which we'll talk about, essentially a play-by-play for how to manage your asthma. So symptoms are still there despite following that and reducing your exposure to triggers, which ultimately are the things that tickle the airway, if you will, and cause that inflammation, that twitchiness of the airway leading to the uncontrolled disease. So that's uncontrolled asthma in a nutshell. But we can get a little bit more granular and talk about ways to identify uncontrolled asthma. So there's some indicators. And the first three I'll highlight relate to medications, and then the last one is just more based on sleep patterns. So top left here, if you're using a SABA or short-acting beta-2 agonist is the jargon, if you're using that quick reliever medication, like albuterol, more than twice per week, that can be an indicator of uncontrolled asthma. Similarly, if you're refilling that inhaler, the SABA, more than twice per year, another clue that your asthma may be uncontrolled. Finally, for medications, if you're using a class of medications called oral corticosteroids like prednisone more than 2 times a year, that's another clue that asthma is uncontrolled or maybe uncontrolled. And then finally, related to sleep patterns, if you are awakened at night because of your asthma, not because you have to get up and use the restroom or you forgot to turn off the stove, but if you're getting up because of asthma symptoms more than twice a month, that is another indicator of uncontrolled disease. So if you answered yes to any one or more than one of these questions, your asthma may not be well controlled, and it's a good time to call your provider and have that discussion with him or her. So now we'll kind of visualize what's going on in the airways. So we've talked about asthma being a chronic disease of airway inflammation, but what does that look like? And one thing I want us to think about, perhaps to better digest this, is thinking about our airways as a highway. And we'll come back to why did I pick that random reference momentarily. But what you can see here is if we start out on the left, this represents a patient without asthma, and you can see that in this airway, there's no inflammation, no constriction, because this light blue color circle is large. The air can freely flow in and out of the lungs, back into the environment, and we can get more oxygen. And this is where the highway example comes from. So this represents midday, minimal traffic, though I recognize with many of you being close to the city, There's never a good day without traffic, so just bear with me here as far as like the example of relevance, but it's midday, it's not rush hour. Then we have in the center here a patient with asthma, and the airways in response to triggers like allergens, smoke, cat dander, they become narrower. So you can see that blue circle has gotten smaller. And this is a result of inflammation, and this makes it harder to breathe. So this can lead to the symptoms that we'll touch on momentarily. And back to that highway analogy, maybe it's not peak rush hour yet, but we're starting to get there. So maybe 7:15, 7:30. And then finally, our patients on the right here have asthma, and this represents an asthma exacerbation or an asthma attack, both the same thing. Ultimately, where there's inflammation, those airways are tightening, your body's producing mucus in your airway, so kind of like snot in your nose, mucus in your airways, further narrowing that passage for air to freely flow to and from. So from a traffic standpoint, this is rush hour. You've got individuals running late. There's a lot of individuals on the highway, so it's going to be congested. Traffic is still moving, albeit slower, just like the air is still moving, but there's less of a passageway for it to flow. So just again, reinforcing that as a result of inflammation and exposure to triggers, your airways can narrow in a patient that has asthma. So what are some of those symptoms that patients may present with, perhaps either yourself or a loved one? And these really can range, and it's important to recognize that oftentimes they're non-specific. So while some of them might, be an indicator for asthma, there could be something else that's going on as well. And we'll talk about the workup that a provider does on the next slide that kind of help hone in that picture for potential diagnosis of asthma. But left to right, you can see that some of the common symptoms include coughing, chest tightness. So we'll want to make sure we're ruling out any form of heart disease there, shortness of breath, wheezing. And really, these symptoms are variable in the sense that you may not experience these every day, but when you experience an asthma attack, whether it's mild, moderate, or severe, these symptoms will increase in intensity. But important to recognize that if I had asthma, my symptoms may be completely different than your symptoms. So everybody's experience of the disease involves different symptoms and is a unique narrative, and also similar when we talk about medication and treatment plans too. So how does a provider make that diagnosis of asthma? Well, first, they collect your medical history. So not only does this include things like current conditions you have beyond asthma, which are important because they can actually lead to uncontrolled asthma when we think about perhaps GERD, which is a condition of the stomach. Some people have nasal polyps that can also lead to uncontrolled asthma. But beyond your medical history, providers are also inquiring about family history. So is there a family history of asthma, of allergic asthma, your social history? Do you smoke? Are you friends with people who smoke? And then also your work or occupational history, because that can be an indicator perhaps that something maybe you're exposed to routinely during working hours is contributing to that lack of control. So medical history becomes extremely important and detailed. Providers will perform the physical exam where they're going to, assess you, look, listen, feel. They'll do some lung function testing, which becomes very important because this is one way to assign numbers to how well your lungs are actually working. And you might hear the term spirometry, which is simply an indicator in a test to assess how your lungs are actually functioning. Symptoms we had talked about. There are certain blood tests that your provider can do that can help identify what type of asthma you have. So oftentimes we may just hear a patient has asthma, but there's actually different flavors of asthma. And I always liken this to ice cream because I'm an ice cream fan. So just like there's multiple flavors of ice cream, there's multiple flavors of asthma as well. Probably the one we think about the most is allergic asthma, but there are other types, and the blood testing can help identify that. And then lastly, FeNO, you may or may not be familiar with. Some practices use it, some do not. But fractional exhaled nitric oxide, it's a non-invasive test, so there's no poking with needles. You simply, as this illustration highlights, you're going to be blowing into this device. And essentially, this can work toward identifying if you have inflammation within your airway. So it's a good indicator of inflammation and perhaps response to treatment as well. So just going to pause there. We've gone through a handful of slides on how common is asthma? How do we find severity, uncontrolled asthma? What does it look like? What's taking place in the lungs? And then how does a doctor, advanced practice provider, how do they diagnose a patient with asthma, or at least consider that diagnosis? But any questions so far?
Waiting for questions from our attendees, but in the meantime, how true is it that to be diagnosed with asthma, you have to be wheezing?
Yeah. So while wheezing is a common symptom of asthma and indicates that airway is narrowing, it's not a required symptom for asthma. And in that same regard, it can be oftentimes challenging to hone in on a diagnosis of asthma, because if we look to some of the um, communities and agencies that are responsible for defining how asthma is diagnosed, it's acknowledged that asthma is a variable disease. So let's say right now we're experiencing symptoms. We make an appointment tomorrow to go in with the provider and talk about these symptoms. They may have subsided and gone away, right? So it's hard to capture that, but wheezing is a common symptom, but not required for the diagnosis of asthma.
Mhm. Yeah, that's another peril for our attendees, because I know a lot of people that are like, oh no, I don't have asthma, it's just a chronic cough, because I don't have any wheezing. And I often say, well, it's better to go to the doctor and check that chronic cough, because it might be asthma. You don't need to be wheezing to be diagnosed. So thank you for.
Yeah, and that's where the blood tests can come in play,
Mhm.
the assessment of lung function as well. So kind of those more objective opportunities where we can assign specific numbers, and symptoms are very important, but recognizing the variability in them as well can make the diagnosis challenging.
Perfect. Thank you.
Yeah. All right. So next, we'll just briefly touch on the immune system as a driver for those inflammatory processes and pathways that we had talked about in that highway slide. So in patients with asthma, irritants and triggers activate the immune system. So I think we all recognize that the immune system is like our internal guard. It's our army to fight the body against the various invaders like influenza, right, or bacteria. And people without asthma usually have a normal response. So exposed to flu, the body generates an immune response, clears the flu, makes a memory about the flu to say, hey, if this comes back, this is what we did. And then from there, the body's response goes back to baseline. But what we see is that in patients with asthma, the immune system can respond to something that it shouldn't, respond too much to something, or you can have an unusual response as well. So all of these can lead to the different inflammation processes that we had talked about. So I mentioned triggers and irritants, but how does this immune cascade, or how do those immune pathways ultimately start? And that's really in response to the irritants and triggers. So if you're outside, you're going to be exposed to a lot of different things, or even if you're inside. So what are those things that you might be exposed to that, if you're a patient with asthma, may lead to that irritation of the airway? Well, we'll take a look at those. And I do want to acknowledge a couple things before we do look at this slide is that one, these irritants or triggers that cause that twitchiness of the airway change over time. And these vary from patient to patient. And it can be hard to hone in on what specific irritants or triggers are causing your irritation of the airways, but that's where an asthma journal can come into play, which we'll talk about. And on average, if we talk about patients with severe asthma, they have about 8 triggers. So perhaps some are more frequently encountered, but on average, patients with severe asthma have about 8 triggers. So just keep that in mind. These triggers, though, some of them I think we're pretty familiar with. Allergens is probably going to bubble up to the top for most of us. Pet exposure, cat, dog dander, pollen from outside flowers, grass. Bacteria and viruses can also be irritants or triggers, as can pollution or smoke. So not just cigarette smoke, but pollution from industry, pollution from cars driving by on the highway or frequently traffic roads. And then I think on the right, maybe some of these we're familiar with as triggers, but some may be less common. Um, Emotions can be an important trigger. So having specific and strong emotions about something can serve as a trigger for individuals. Exercise with that increased demand, perhaps it's cold outside, that can lead to irritation of the airways and inflammation. And then also weather and climate. And with climate change taking place right now, that can further lead to some increased responses and exacerbations for patients. So what is this whole, how does this play out? So what we know is that in a patient without asthma, they have that open airway. But in a patient with asthma, what happens is that these airway irritants or triggers, again, both the same word there, they interact and they're inhaled and they interact with the surface of the lung. Epithelium is the scientific word there if you're reading that, the surface of the lung. And then from there, we get those immune cells that are activated. We get that inflammation and that constricting, and it becomes rush hour. And then ultimately, as a patient or a loved one that we're managing with asthma, you see those symptoms start to come to light. So that's kind of how this all plays out in a nice overview model. So if you're more of a written individual in terms of learning, this is essentially capturing the same information that those triggers will turn on the immune cells, specific ones. So kind of a lock and key approach with certain triggers turning on certain pathways in immune cells. From there, those immune cells will lead to specific responses, and that can ultimately lead to different treatment requirements, which is why that those blood tests become important in terms of working to identify perhaps what might be the most appropriate treatment for you. And your doctor can review the results with you, and then based on those results in your discussion, the appropriate treatments. And then finally, we'll round out the presentation with the role that you can play, or perhaps if you have a loved one with asthma, how you can support them as a caretaker as it relates to their care. So when we talk about management of asthma, there's really a hallmark here that includes 3 different foundational pieces, and this is your asthma action plan. So the 3 different pieces that make up your asthma action plan include lifestyle modifications, your asthma journal, and then finally medications. And the goal here would be to outline ways to reduce and importantly treat those asthma exacerbations, how to manage the symptoms, and then gain control of your asthma. And really this asthma action plan is a discussion, and it's an ongoing discussion with your provider to understand what to do during specific situations. Now, importantly, if you are experiencing an asthma attack, do not pass go, call a provider and seek care immediately. And then lastly, it's important that you refer to your asthma action plan regularly because, again, it is a working document. It's not just one and done. Recognizing asthma symptoms change, triggers change, it should be an ongoing discussion with your provider. So what does the asthma journal look like? This can vary. If you prefer to write, you can use a traditional journal style. There's electronic journals online as well, lots of resources out there. A lot of the organizations that are in the respiratory or lung space have asthma journals that are free to download. And I'll highlight those at the end. But what you consider tracking in your asthma journal are peak flow, which is a way to assess your lung function at home, non-invasive, quick, easy assessment method. Anytime you might be experiencing an exacerbation, working toward tracking triggers and associating if those triggers are related to symptoms as you're working to identify those. Because again, on average, 8 is the number of triggers a patient with severe asthma has. Any rescue medication use, steroid use, or impact on daily life, such as work, school, sleep, etc. All of that can be captured in your asthma journal, which what you want to bring and share with your healthcare provider. So what are some lifestyle modifications that you can do? And we've alluded to some of these, like when we talked about quality and affordable housing. So around your home, you can vacuum the carpets, ensure that you wash your sheets and blankets. As it relates to the bedroom, not only washing your sheets and blankets, but considering allergy covers, limiting pets in the bedroom, especially if they are a known trigger for you. If you have certain allergic triggers like pollen, sealing doors and windows, especially as pollen season begins to increase, and minimizing any pests or rodents in the house as well, because those can be triggers for certain individuals. And then kind of just a more well-rounded approach that, is important for asthma and really beyond asthma are healthy choices. So maintaining a healthy weight, which will allow you to be more active, minimizing the weight on your chest as well to allow for easier breathing, ensuring consumption of heart-healthy foods, practicing any breathing exercises, right, for meditation and to minimize stress, which can be a trigger, where you can avoiding tobacco smoke and healthy sleep habits. And I'll be the first to admit that I'm guilty of screen time before bed, but not the best thing, but definitely opportunity for improvement. And importantly, your provider may have suggestions that are not called out on this slide. So working to pull through those recommendations that your provider offers as well. And then finally, as we round out the asthma action plan, the medications that you take are going to be an integral role. And similar to symptoms, these treatment plans are unique for everybody. So what one person may take may look similar or completely different to what another individual takes. But just briefly here, we'll start at the top left and then work our way around. Um, uh, all patients should have a short-acting or rescue medication available and handy to manage the asthma exacerbations. And these are going to work to quickly open up the lungs to allow for the air to get in, but they're only as a rescue medication for as-needed use. Then on a daily use, we have our long-acting controller medications that really work to address the underlying inflammation with asthma. So unlike the inhalers that I talked about above, the short-acting rescue ones, the long-acting controllers, which are oftentimes inhalers, there are pills as well, but these are meant for daily use. Then you might hear about oral steroids like prednisone. These are oftentimes used during an asthma attack. Some patients may be on these long term as well for asthma control. So you might see different scenarios. Biologic medications, these are very targeted medications for patients with moderate to severe uncontrolled asthma. And really, that's when we talk about blood testing and for some of them and such. And then finally, allergy medication. So if you have a specific flavor of asthma, remember there's a lot of different flavors. If you have a specific flavor of asthma, allergy medications may be an option to help control the allergic component. So that rounds out the presentation. We've talked about how common asthma is. Again, 25 million plus individuals within the US have asthma. Over a million have severe uncontrolled asthma. We've talked about the role that the immune system plays, and then finally rounded it out with how you, as a patient or a caretaker for a loved one, can manage asthma and become better empowered to control asthma. So I'll leave this up here for a moment, but these are just some different resources I alluded to as far as additional educational content, the asthma action plans, asthma journals that you can access for free download on the American Lung Association, Allergy and Asthma Network, and then our own homegrown resource, which is Luma, that I'm presenting the content today.
Well, thank you so much, Matt, for this
Yeah.
presentation. It's very enlightening, as always. That's why I like to have you here. Thank you so much.
Yeah.
And this is the time for our attendees to make the time yours. So please start writing any questions, any comments in the chat or Q&A, and we're going to be ready. Well, he more than I am. I will, but Matt will be ready to answer all your questions. Any last minutes thoughts, Matt? Anything that we should know?
Yeah, a couple of things. One, just kind of working backwards, I can recognize and appreciate, once a patient's identified as having asthma, how challenging it can be to identify triggers. So, pull through that asthma journal to work toward identifying that. And it'll take some time, and you may identify many based on, some of the data that we know. But we have lots of options to manage asthma and better maintain control. And then in terms of minimizing risk as well, just thinking about perhaps the flu vaccines and different strategies that you can employ to minimize risk for any flu-related complications in that spirit of the National Influenza Vaccination Week.
Okay, well, thank you so much. And I don't see any questions or comments. So I think we are ready to move on, and I will see you next week. Actually, we don't have one because something is happening here at the hospital.
Yeah.
I have a meeting to attend. But then in 2 weeks, we're going to be talking about bipolar disorders. So very different topic. So join us for that as well. And Matt, happy holidays, and stay
Thank
tuned
you.
because we need to plan for next
Yeah,
year. Okay.
absolutely.
So, and
Thank
thank
you all
you,
for your time.
and thank you to all of our attendees. See you soon. Bye bye.
All right.